Okay, so we're recording now. Hello, everybody. My apologies for the slightly delayed start. We were running into some IT problems. My name is Shwan Hanari. I'm one of the mentors in the FRCS preparation group. Today we are having a lecture from Mostafa Elgendy. He's recently passed the international exam. He works in Suleimania Hospital in Jeddah, Saudi Arabia. Welcome, Mostafa, to us. Other mentors that are here with us today is Abdullah Hanoun, Hani Pardasi, and Chitan Georgi. We're very pleased to have you all here as mentors, and we're also very pleased to welcome all our participants. We look forward to working with you in the future. At the end of this lecture session, you will have Viva sessions. Please stay on. The Viva sessions are not recorded for obvious reasons, to give you, first of all, some privacy, but also to allow you to be free to express yourselves. Mostafa is going to give us a talk on SUFEs, please. Thank you, Mostafa.
Hot topic for FRCS exam for both first part and second part. I'll start from definition until we reach the complication and the management. I try to cover the whole speech for the both part 1 and part 2. The second part, it's very important and hot topic. I try to cover every point in this one, because I think in this case, if the examiner gives you this scenario, you have to at least pass by 7 or 8 at least. So what are our objectives today is to know what is a slip, why and how it happened, how it can be diagnosed, what are the classifications, what are the treatment options, and what is the complication. Starting by definition, it's disorder of the proximal femoral epiphysis that lead to slippage of the epiphysis. The epiphysis stays in the sternum while the neck displaces anteriorly and externally rotate. So the epiphysis stay in the posteriorly related to the femoral neck, and this is very important information, because it will affect everything in the clinical picture of the patient and in the management of the patient. So the epiphysis is remaining in the sternum, but the femoral neck is displaces anteriorly and externally. So what is the epidemiology? The incidence, it is the most common disorder affecting the adolescent, happening in 10 per 100,000 population. It's more common in obese children, and there is a single greatest risk factor. Male to female ratio is 3:2. African American, because they have huge body mass index, and during the period of growth, it's called growth spurt. So the average age is 13 for boys, 12 for girls, and it's associated with puberty, as we said, because of the growth spurt. Location, the left hip is the most common one. They don't know why, but they think that because of the sitting posture of the right-handed children while they are writing. They said that the handwriting people, when they are sitting on the right sitting position, the left hip is affected more, and it's bilateral in 17 to 50%. What is the etiology? It's either mechanical factors or endocrinological factors. What about the mechanical factors? Number 1 is because of thinning of the pericordial ring of Lacourrois complex. All of us know this is the morphology of the epiphysis. As we can see here, this is the articular cartilage. The articular cartilage is classified into the resting zone or the reserve zone, and the proliferative zone, and the hypertrophic zone. As we can see here, the hypertrophic zone is subclassified into the maturation zone, degeneration zone, and zone of the provisional calcification. Here we have what we call the pericordial ring of Lacourrois. It's a dense fibrous tissue encircles the epiphysis, and it's supporting the physis. This is the one. And this is the most important structure supporting the epiphysis from slippage. So in patients with slip, they found there is thinning of this pericordial ring. Number 2, there is change in the inclination of the proximal femoral physis relative to the femoral neck. What they found many patients with slip, the physis is become vertical, lead to increase the shearing forces at the epiphysis, lead to its slippage. Number 3, they found many patients with slip has retroversion of the femoral neck. What are the endocrinological factors? It's occurring in an obese hypogonadal male, and it's called the adolescent syndrome. Occurring more common in hypothyroidism patient and the patient with chronic renal failure or renal osteodystrophy. The classifications. We have many classifications for SLIP. We can classify it into the patient if clinically stable or unstable, and we'll speak about it. And radiomorphological classification into mild and moderate and severe, we'll speak about it. And temporal classification according to the onset of symptoms into acute, chronic, or acute on top of chronic. First, starting by Luder, it provides prognostic information, and this is a very important classification. He classified SLIP into stable and unstable. Stable means that the patient has able to bear weight even with or without crutches. Why this is important? Because there is minimal risk of osteonecrosis, less than 10%. And the unstable patient, this patient has unable to ambulate even with crutches. Why this is important? Because it's associated with high risk of osteonecrosis, 47%. Why the unstable cannot be weight? Because they said that there is micromotion between the epiphysis and the physis. So there is pain, there is inflammation, synovitis, the patient cannot bear weight. So this is unstable and high incidence of avascular necrosis. Temporal classification, he classified SLIP according into the onset of symptoms into acute. If the symptoms is less than 3 weeks, this patient has prodromal symptoms and due to minor trauma. Why these three are important? Because we have to subdivide or doing like we have to classify this from the traumatic Salter type 1 fracture, because traumatic Salter type 1 fracture, this patient has greater energy trauma and has no prodromal symptoms. So this we have to classify traumatic slip from acute slippage occurring with prodromal symptoms. The radiograph for acute slip has no femoral remodeling changes typical of chronic slip. As we can see here, this patient has slippage here and there is no any remodeling changes. So this is acute slip. In chronic slippage, the patient has symptoms more than 3 weeks, and we have here, as we can see, there is remodeling changes. Acute on top of chronic, the patient has prodromal symptoms more than 3 weeks, but the patient has sudden exacerbation of the symptoms. So how we can differentiate acute on top of chronic from chronic? If the slippage occurring more than the degree of the remodeling, beyond the remodeling point, so this is acute on top of chronic. As we can see here, there is remodeling changes here, but the slippage occurring more than the remodeling stages. Southwick classification, he classified slip according to the epiphyseal shaft angle. He's measuring the angle in the AP view, and the normal angle is 145 degrees, and in the lateral view, the normal angle is 10 degrees. He's taking line parallel to the epiphysis from the upper end to the lower end, and take perpendicular line and line with the shaft of the femur, and the normal angle in the AB 145, the lateral degree is 10 degrees. And he's doing comparison between the affected side and the normal side, and he will measuring the difference between both of them. And if the patient has bilateral slippage, he's taking the normal degree, 145 degrees, as reference. But if the patient has only unilateral, he's comparing this side to the normal side. So the Southwick classification classified the slip into mild if the angle is less than 30 degrees, the difference between both sides, moderate if 30 to 60 degrees, and severe if it's more than 60 degrees. Grading system for slip. The grading system into mild and moderate and severe. If less than 33%, from 0 to 33%, it's grade 1. 34 to 50, it's grade 2. And grade 3, more than 50% of the slippage, as we can see here. Less than 1/3 to more than 1/3 to 2/3, more than 2/3. How the patient is presenting to the clinic. Many patients coming complaining of groin pain or thigh pain. This is the most common presentation, thigh pain or knee pain. And it's occurring from 15 to 50%. Why knee pain? It's transmitted through the obturator nerve. This is why it's misdiagnosed, because patients come complaining of knee pain or thigh pain, not hip pain. Physical examination, we see the patient has maybe antalgic gait or Trendelenburg gait, and there is decreased range of motion of the hip, especially the internal rotation, abduction, and the flexion. Dreeman sign, it's obligatory external rotation during the passive flexion of the hip. Why is this happening? Because when we are doing passive flexion of the hip, we see the thigh and the hip become external rotated, because there is impingement of the displaced neck on the acetabular rim. And if the patient is chronic, we can see there is some thigh atrophy. Radiological finding. As we all know, there is the Klein line. It's line line drawn through the superior neck, tangential to superior neck, and has to cut, this line has to cut a piece of the head from the epiphysis here. As we can see here, this line is not cutting anything here in the epiphysis, so there is slippage here. It's called there is one sign, as we can see here also in this diagram. And this is a second radiological finding. We can see this is called the metaphyseal blanche sign of steel. It's a crescentic shaped line, radiodense due to overlapping between the slipped physis, because the physis slipped posteriorly, so there is superimposition between the neck and the slipped physis. It will appear in this line. Another radiological finding we can see here, this is called epiphysiolysis or widening of the epiphysis, as we can see here in comparison to this side. And this is early radiological finding. We can see even before slippage. Also, we can see decrease in the epiphyseal height. If we measure the epiphyseal height in this area and compare to this epiphyseal height in this area, we found this decreased epiphyseal height. Because as we said in the beginning of the definition, the physis is displaced posteriorly relative to the neck. How we can manage the patient? There is very good algorithm. It's published in the SICOT 2017. They said slipped can classified into, as we said, stable and unstable. If the patient has unstable, high incidence of AVN, about 50% of the patient, so try to save them by doing modified Dunn approach through safe surgical dislocation. I will speak about it later on. If the patient is stable, how much is the degree of the slippage? It's mild, less than 30 degrees, moderate or severe, more than 30 degrees. If it's mild, less than 30 degrees, they are saying if it's impinging or non-impinging. What's the difference between impinging and non-impinging? They said impinging if the patient clinically has hip flexion 90 degrees or less, or internal rotation 15 degrees or less. So if the patient has internal rotation 15 degrees or less, or flexion 90 degrees or less, this is called impinging. So if it's a non-impinging, they are doing in situ fixation. If it's impinging, they do in situ fixation plus osteochondroplasty. And I will speak also about the osteochondroplasty. But if the patient has moderate or severe slip more than 30 degrees, they are depending on the open physis or closed physis. If the patient has open physis, they do safe surgical dislocation. Plus subcapital realignment. I will speak about it. But if the patient has closed physis, they are doing combined intertrochanteric osteotomy with osteochondroplasty. How we can do percutaneous in situ fixation? This is the main management for the patient. I will speak about how we can do the technique. But what about contralateral in situ fixation? Can we do prophylactic pinning for the other side or no? It's remain controversial. The current indication are if the patient has high risk patient, because there is contralateral slippage 40 to 80%, like we said in the adipocogenital syndrome, renal patient, hypothyroidism. And if the patient initial slippage occurring at young age, less than 10 degrees, this patient may also have open triradiate cartilage. Or the nature of the current slippage is very severe, means that the patient is coming to the clinic has very severe slippage. And the adding one more point, if you cannot do close follow-up for the patient, if you cannot trust the parents, and you can find that the parents will not do follow-up with you, so you can add this in prophylactic fixation. But they tried to find another algorithm to become more secure on how to do prophylactic fixation on the other patients. So what they did the modified Oxford score. The score is combined of 5 categories: the ilium, the triradiate cartilage, the head of the femur, the GT, and the lesser trochanter. Every one from this is taking point. Like as we said here, if we take the triradiate cartilage as an example, if the physis is clearly open, it takes 1 point. If the physis is partially closed, it took 2 points. If the physis is closed, it takes 3 points. And every one of these taking points like 4, 5, 6, 3, 4, 5. So the least score, if we calculate this one, the least score is 16, and the highest score is 26. Why this is important? Because they found this. If the patient score is 16, there is probability of developing contralateral slippage 100%. So you have to do prophylactic fixation for this one. And if the score of the patient is 26, the probability of developing contralateral slippage is 0%. So you cannot do prophylactic fixation for this one. How we can do percutaneous in situ fixation? The aim of this is to stabilize the epiphysis from further slippage. We are trying to promoting the closure of the proximal femoral physis. it's a minimum 3 threads crossing the physis. I read in many literatures they are saying 5 threads. Really, when I'm saying the screw and the epiphysis, it's very, very small. I don't know how 5 threads crossing without penetrating the physis. But I found that minimum 3 threads is safe. Screw should be at least 5 millimeters from the subchondral bone in all views. This is the most important sentence. The ideal placement of the single cannulated screw should be in the center of the capital epiphysis, and it should be perpendicular to the physis. So the screw should be in the center of the epiphysis and perpendicular to the physis. After fixation, if the patient is stable, he can do pair weighting after in situ fixation. But if the patient is unstable, we make him non-weight bearing. This is how we can do in situ prophylactic in situ fixation. As we can see, we put the patient supine on the traction table without drawing any traction. Then we take AB shot. We take the one wire, and this wire is perpendicular to the physis, as we said, and in the center of the epiphysis. And we draw this line in the patient skin, and then we take lateral shot, and we take another line perpendicular to the physis, and in the center of the epiphysis, and the intersection between the 2 points is the entry point. As we can see here, this is in the AB, and this is in the lateral, and the intersection point between the AB and the lateral is the entry point. And then we are fixing the screw. Why is this important? Because they found in this diagram, as we can see, there is 3 bends here, bin A and bin B and bin C. Bin A and bin B, both of them are trochanteric entry bends, and bin C is anterior in the neck. Both bin A and bin C, as you can see here in the image, if you can see in the image, it will become like false deceiving. It's perpendicular to the physis and then center of the epiphysis. But if we can see here, they are not crossing in the center and they are not fixing good. So this is why we have to make the bin C, the anterior of the neck, by intersection of the 2 points. How about proximal femoral osteotomy? Why we are doing the proximal femoral osteotomy? To restore the proximal femoral anatomy. Why? Because if we're not restoring the proximal femoral anatomy in patient with untreated or chronic slip, the patient will complain of femoral stubborn impingement later on, and it will have labral or articular cartilage damage, and later on degenerative changes and osteoarthritis. We know that we have 3 types of osteotomy. We have the done of subcapital osteotomy, and we have basal neck osteotomy. It's called the Kramer or Bramada, and we have the intertrochanteric Southwick osteotomy. Why is this important? Because all of us know the more the proximal the osteotomy, as we can see here, the greater the correction, the degree of the deformity. But the problem, because why this is greater degree of correction? Because it's near to the center of the rotation and angulation, it's near of the center of the cora. But the problem, it's near to the blood supply, so high incidence of avascular necrosis. What about osteochondroplasty? The indication if the patient has symptomatic femoral stubborn impingement from metaphyseal bump in mild or moderate degree of slippage, and we can do it either arthroscopic, as we can see here. It's only about reshaping the neck or shaping the neck, or can do by through limited anterior osteotomy or surgical dislocation. What about open reduction with capital realignment? It's called safe surgical dislocation or surgical hip dislocation. It's epiphyseal reduction with pinning. It remains controversial. It's indicated in unstable or high degree slippage because this patient has high incidence of vascular necrosis. We are doing surgical dislocation with epiphyseal reorientation through modified Dunn procedure. The superficial interval between the gluteus maximus and the gluteus medius, and the interval down between the gluteus minimus and the piriformis. The success of this approach depending on protecting the blood supply. In this diagram, we see why when we are doing osteotomy, we have to do shortening of the neck. Why the patient, if you have patient with chronic slippage, why you are not doing for him closed reduction and fixation only? Because the remodeling changes, and after slippage, as we can see here, there is retinacular vessels become kinked. And if we are doing closed reduction, traction, there is a template of closed reduction, the blood supply only become from the ligamentum teres. So it will affect the blood supply, and the patient will have a vascular necrosis later on. So if we try after doing osteotomy or safe surgical dislocation, we are trying to do shortening of the neck. So with the reduction, the blood supply is still kinked and it's not affected. How we can do surgical dislocation? Supine position, the anterior superior spine and the GT. We are incising about 15 centimeter. We're opening the skin. After this, a tensor fascia lata, as we can see here. Then we find our interval between the gluteus maximus, and to do internal rotation, we find the gluteus minimus and the piriformis. And then we are finding the GT. We are doing flipped trochanteric osteotomy. It means the transverse osteotomy in the GT. Now we can see here the capsule. We are doing Z-shaped capsulotomy in the capsule. Then you dislocate the head. After dislocating the head, you subluxate the epiphysis anteriorly, depending on the intact posterior tracheal vessels. We are not disturbing the posterior tracheal vessels. Then we are removing the whole callus formation. We do osteotomy in the neck, reshaping. Then we reposition the epiphysis again and we fix it again. As we can see here, we are not disturbing any posterior blood supply. Then we are fixing by key wires and the screw for the GT. What about the complication of slippage? Contralateral hip slip progression in 1 to 2%, infection 0 to 2%, and chronic pain 5 to 10%. If the patient is not treated good, he has degenerative arthritis or residual deformity. It's called the best grip deformity. All this not important. The most two important complication is the EVN and the chondrolysis. EVN occurring as a result of the initial trauma itself or due to operative intervention. If we put the screw in the posterior superior femoral neck, this patient has high greatest of the risk of disrupting the blood supply and high incidence of vascular necrosis, as we can see here. The most important, second important complication is the chondrolysis. As we can see here, comparison for this articular cartilage here and joint space, there is narrowing in joint space here. The patient came complaining of stiffness and the persistent pain in the groin or upper side. Examination, we have the patient loss of arc of the motion in all the planes. How we can diagnose? There is loss of joint space, as we can see here. And the radiographic criteria for this, if the joint space less than 50% in comparison to the other side, or absolute measurement of 3 millimeter or less. This is the whole presentation. Thank you.
Thank you very much, Mostafa. The presentation was very good. I have a few questions for you, but I'll first put it out to the audience. If anyone has any questions, please feel free to unmute your mic, ask the question, and then remute. Kashif, please go ahead.
Yeah. Thank you, Dr. Mostafa. I'm not a mentor. I'm a candidate for the May exam actually, but I failed the November attempt. I think this was a brilliant presentation, but I think there are 2-3 very important things which the candidates like us, we have to understand. That the most important thing is the controversies which they usually ask in the exam. 2 or 3 controversies, and one of them you have already mentioned, that will you pen the contralateral hip or not? And the second controversy is that the presentation, the time of the presentation, when you are going to operate on an acute or acute on chronic and chronic. If you can explain this, because it is written in the postgraduate book. And I think it is quite an important thing that the time of the presentation and operation, I think it is quite important. The Southampton paper of the Clark is the basis of this controversy, if I'm not wrong. Sean, just correct me if I'm wrong.
Well, first of all, you're right. There is some controversy about time to operation and who is going to operate. Yeah. And second, discussion about you should open reduce or pin in situ. I don't agree with that. So I will first let Mostafa give his opinion on this.
Sorry, I didn't hear the question again.
The controversy regarding the timing of the surgery. On acute patients or chronic patients. They say that if the presentation is delayed more than 24 hours, then don't operate on those patients. let that patient to be converted on a chronic slip and then operate on that patient. And the most important thing that this surgery has to be done in a specialist center in a high tertiary care hospital, not in a DH district hospital, what they call in England district general hospital.
Okay, according to what I read and what I searched for, yes, I read what you read, that if the patient has come and is more than 48 hours, you don't treat him as acute, and you wait for the patient until become chronic and you do correction later on. But if the patient is coming to you with severe slippage, like more than 60 degrees, this patient has high incidence of vascular necrosis already. So yes, you can transfer him for tertiary center. They are all now speaking about the safe surgical dislocation and trying to reposition the neck. Even if the patient complaining later on of vascular necrosis or chondrolysis because of the procedure itself or because of the trauma itself. So the patient is 50% has a high incidence of vascular necrosis with severe slippage and unstable slippage. So you can wait until the patient become chronic, and then you can do osteotomy for him, or you can send him for expert one and he do surgical dislocation for him. Did I get your point?
Yeah, you're right. You're right, Dr. Mostafa.
Add some information here. Hello. Hi, Sean. Can I add some information here?
Dr. Shwan, you are muted yourself.
My apologies. Yes, sorry, I didn't realize I was muted. Sorry, who's speaking?
Can I add some information here?
Yes, but who's speaking? Sorry.
Yeah, this is Chetan.
Okay, go ahead.
Yeah, so I prepared the answer in a way that you classify mild, moderate, and severe severity. Then if it is grade 1 and 2 and it's presenting anytime, you can treat it the next day. But if the management would be initial A&E management and definitive management. First, A&E management would be pain relief, admit the child, exclude other differential diagnosis, take a history, any risk factors, then you can treat it next day. So if it is grade 3, a severe slip, if it is presenting less than 24 hours, then you say principles of management here. You say that you discuss this with a tertiary pediatric referral center. Say that this treatment is controversial. You say that there is a BOS study is going on about the exact epidemiology and the ideal way of treatment. There are various school of thought. I'm aware that Southampton paper, Oglo and Clark, but that's their view. But there are a lot of other school of thoughts. They examiners, they're different examiners. They think differently. So don't stick to just say it's a controversial. Say you involve, if it is less than 24 hours, you talk to the referral center, tertiary referral center. It needs pinning. So also whether to manipulate or not is controversial. Most of examiners say don't manipulate because the risk of AVN is too much. So most of I attended Mr. Bajaj's course. His way of teaching is that he says you can gently manipulate by putting the patient on traction table, but don't put the traction on, but let the hip reduce back on its own, and then you can pin it within 24 hours. But if the child comes to hospital after 24 hours, then you have to treat it, convert it into chronic slip, and then treat it after 10 to 14 days. You can do open pinning, open subcapital osteotomy, and you can do open procedure. So that's what he says. So, but just you have to, main thing is any management, definitive management, say about controversy, say about post study, all these things. He says gentle controlled close reduction to bring to a fixable state and fix in situ. That's what he says.
Thank you, Chitan.
Can I add one thing? All these controversies you have to be aware of. However, the typical exam answer should say that I would follow the local guidelines. The setting in the UK is for each DGH, which you are expected to be a consultant in, you would have a center for pediatric operations. And there would be like a local guidelines telling you what to do in these cases. So the first word that should come from you in the exam would be, I would follow the agreed local guidelines with the local pediatric unit. Some units would insist on sending every single patient to them so that they could deal with it because they are part of a research or they have a particular interest in this. Others would say, no, you would deal with stable, grade chronic or higher grade, you'd immediately refer to the other unit. However, then you can talk, they will tell you, okay, you are at the receiving end, and exactly as Mostafa was explaining, you go on to the following things. But the first thing is safety, and safety is you're a DGH consultant, you follow the guidelines set by the experts. Thank you.
Absolutely, Abdullah. That is wonderful, wonderful.
Thank you very much, Mostafa. Chitan and Abdullah both are very valid and correct points. If anyone else has any questions, please do raise your hand or unmute your mic and ask. But if not, I do want to ask a couple of questions of our mentors and see what they think. So one, Mostafa, do you mind unsharing your screen now? Thank you. Thank you, Mostafa. So one of the questions is your 13-year-old boy presents to A&E with, essentially you get to the SUFE part, to the slipped capital femoral epiphysis part, and you've made your diagnosis. Now they're going to ask you if it's acute or not acute, or you've already established that. What do you do with the patient? It's 11 o'clock at night. Do you send the patient home? Do you admit the patient? So on and so forth. The testing is sometimes in that.
They said if the patient come to you, number one, don't let the patient walking. You have to make the patient on, if he's stable, he can do bit with bearing, you put him in wheelchair. Don't let him go home without wheelchair. Don't let him go home walking. If the patient are unstable, put him in a stretcher, not even wheelchair. And not allowing him to go outside the hospital, because 50%, 1 in 2 cases, will have a vascular necrosis. Then 11 o'clock in the night, no, you will not do surgery for him. You will wait in the morning and you consult the pediatric section. If they have the ability to do safe surgical dislocation for the unstable one, it's better for him, because they are trying to saving his neck more and saving the epiphysis without a vascular necrosis. But if he's stable, you can do prophylactic fixation for him only. And there is one thing I forget to mention. If when you are sending the patient to X-ray, you are doing AB and cross-lateral table, not put the patient in frogolateral. There is controversy in this. They are saying if stable, you can do frogolateral position for him. But if unstable, don't put him in frogolateral. But the most safe answer to do AB view and the cross-lateral table view. Don't do any manipulation for the hip.
I agree. So the other controversy in the, mentors, any different viewpoints, anything?
I agree entirely. I agree entirely with you, Mostafa.
And the other controversy is about who does the open reduction and the techniques. So as a reminder to everybody, there is nice guidance on open reduction of slipped capital femoral epiphysis. I'll put it on the FRCS Telegram group. It is worth quoting this because, as you all know, if you quote nice, it's equivalent to quoting literature. And if you understand exactly what they're saying, remember, if you quote anything like that, you must know exactly what they're saying. Okay. Just as a summary, a couple of things they are saying that should be performed. First of all, you should speak to your, if you as a surgeon plan to do this, you should speak to your clinical lead and your greater referral team to make sure that you've got support, but also the equipment and the referral pathway ready for that. But also, if you are doing these procedures, they need to be registered with BISCOS. So they can measure and check the outcome as part of ongoing assessment. Okay, so that's just a quick summary. You guys would need to read this all up. I'll put it up in the FRCS Telegram group, or later on it will be available for everyone. If there's no more questions from the audience and there's no more comments from the mentors, I'll give a minute for anyone to think of a question. We'll move on to the Viva part of this. Thank you very much, Mostafa. And again, thank you to all our mentors. Please stay on the line now until we disconnect the recording part. We'll start the Viva part in a minute, okay? Thank you very much.